Hello, and welcome to GAPNA Chat, an official podcast of the Gerontological Advanced Practice Nurses Association. GAPNA Chat provides interviews and discussions with GAPNA leaders and members of the gerontological healthcare community, and will focus on advocacy, policy, education, professional development, research, and clinical care for older adults. Before we get started, a practical guide for the gerontological specialist is now available for purchase in the GAPNA store. This text is a handy resource for anyone caring for older adults and is helpful to those preparing to sit for the Gerontological Specialist Certified exam. Visit www.gapna.org to get your copy. In this episode, Dr. Cassandra Von Ness, a gerontological nurse practitioner and member of the GAPNA communication team, talks with Jennifer Pettis, the Director of Strategic Alliances at the Gerontological Society of America. We are pleased to present Dr. Von Ness's interview with Ms. Pettis.
Welcome, everyone, to our 5th season of GAPNA Chats. And today we have Jen Pettis from the Gerontological Society of America. Jen is a master's prepared RN who is certified in nursing education, and she is the current director of strategic alliances at the GSA. Jen also directs the development and production of strategic alliance programs to further the Society's mission and strategic goals by providing thought leadership to drive growth and new opportunities involving existing or potential new partners for the Strategic Alliances Division of the Society. Jen also provides subject matter expertise to the Centers of Medicare and Medicaid Services regarding the MDS, or the Minimum Data Set Resident Assessment Instrument. She is a member of the Alzheimer's Association of Northeastern New York Board of Directors and an active community educator for the Alzheimer's Association, as well as a volunteer lead trainer for the AARP's Disrupt Aging Classroom program. In 2020, Jen was recognized by the National Hartford Center of Gerontological Nursing Excellence as a distinguished educator in gerontological nursing. In 2021, she received Sigma Theta Tau's Amy J. Berman's Geriatric Nursing Leadership Award, which is an international award bestowed upon an individual who has demonstrated contributions to collaborative practice through involvement in interprofessional teams and defined commitment to gerontological nursing. Hello, Jen. Thank you so much for being with us today.
Thanks so much for having me, Sandy. It's a pleasure to be here.
Even before your position at GSA, you've been involved in education and also improving the care for older adults. Your love of gerontology started in high school when you worked as a nursing assistant in a nursing home. What would a 21-year-old Jen think of your career path?
Sandy, I love this question. As I thought back of what would my 21-year-old Jen think, I thought of where was I at 21 years old, and I was having my very brief stint in acute care because everyone was told they should at the time, and I couldn't wait to get back to the nursing home, which was really my love of taking care of people the way I would want to be taken care of. I remember at the time I started in nursing homes before OBRA 87 was even the lay of the land. And as I think back to when there were federal regulations promulgated and suddenly a state operations manual, I can remember surveyors coming in and saying, "Oh, you all did such a good job here." And we thought, well, we just did the golden rule. We did what we would want someone to do for our moms or grandmoms. And then someone actually said to me, "Do you know there's a manual about this?" And I was like, "You're kidding me. There's actually rules about how we're supposed to be taking care of the people." We just all did at the time what we thought was the right thing. And somehow that always guided us to do what was right. And as I think back of that, it's certainly become a more complex world. but I would never dream at 21 that my career would take me, away from the bedside and into education and policy work and consulting and traveling around the country to share things with others. And I guess if I would just think back to this career path I've had, I often think about, regardless of my career, the stage of my career, it's all been about colleagues and mentors and finding those people who are eager to connect you with the next person. And really that's how I've landed where I am in my career path. And I always say to any nursing student, whether they want my advice or not, to get involved with your professional associations, really get involved with them. Don't just sign up for them. And then to find mentors, regardless of the stage in your career, and just learn from them and learn with them, and then find people who you can bring along as well. So I think that's really important advice. And I wish my 21-year-old knew a little more about that.
Well, we are so fortunate to have you escaped from the acute care realm to,
Yeah.
to help us in care of our older adults. And there are so many initiatives and questions that I have for you about the GSA. It was hard for me to start. So let me just start with the National Center for Reframing Aging. I know we try to talk about this discussion about getting older, and it's even more important for us as we become our population of interest, right? That we frame that. And I recently showed the AARP millennial video to some nursing techs that I was teaching, and it made quite an impact. I'm intrigued, and I want to ask you to talk about Disrupt Aging Classroom and your role as a lead trainer.
Sure. Disrupt Aging Classroom is one of my 2 volunteer passions. And before I tell you about that, I want to just mention, because you brought up the National Center to Reframe Aging, today is actually their Summit 2024, where they're looking at the movement to reframe aging and really looking at that collective goal to think differently, to think, communicate, and act differently, as we really, we share this experience of aging, and it's a universal experience. And I think that message of we are all aging is such a vital message. And it made me so happy last year or 2 years ago when I was putting in an abstract for GAPNA. There were the GSA, the National Center's principles for how to use inclusive language right in the GAPNA information about writing proposals. So I thought, isn't that great, this cross-pollination of great ideas, working with the associations to collaborate. So my introduction to Disrupt Aging Classroom started actually at the GSA 2019 annual scientific meeting in Austin, Texas. There was an early morning breakfast that was being presented by a group called Borrow My Glasses and AARP Connecticut. And they were sharing for the first time this information, this program at the time, which was an in-person program provided only in Connecticut. And it's provided as a call by Joanne Jenkins, the CEO of AARP. She wrote a book called Disrupt Aging, and then charged all of the state chapters to really figure out how to operationalize it, how they would put it into place in their chapter. So the Connecticut chapter partnered with this group, Borrow My Glasses, and really made this experiential training called Disrupt Aging Classroom. And I was just blown away with the training, with how they used different online platforms and really experiential learning for traditionally college-age students to bring this program to a classroom regardless of what the student's major was. So it wasn't just for healthcare students, it was for design students, criminal law students, you name it. They could come in and just begin to consider, how would this trend of aging, of our aging population, really impact their career choices? And then they had said at that time, we're going to be expanding this to states outside of Connecticut. And I said, sign me up. I want to be involved in that. So I began to get involved as a volunteer. And then poof, we had the COVID pandemic hit, and all of a sudden all the learning was online. And myself and then 2 other educators were engaged by the group to actually redesign the class to be a fully online class. So that was really fun to be involved in how we could transform that from in-person to this online experience. And then we got to teach it online. And I can remember teaching a very early morning class. I tend to do the early mornings. And I thought one of the students was actually asleep. He kind of had his blankies up over his nose. And then all of a sudden he shouted out the answer. I was like, oh my gosh, I guess he's just cold. He's not sleeping. But it's such a wonderful program. And as one of the lead trainers, I have the opportunity to help train new volunteers. It's fully volunteer trainer workforce, so to speak. And so I have the opportunity to train others, to give them feedback on if they're submitting a video to be, approved as a trainer, to provide them feedback. And then when someone's struggling, to help kind of mentor them along. So it's really very fulfilling. The curriculum is fabulous. The best thing about it from an educator standpoint is it's totally free. AARP comes into their classrooms virtually and provides the training. So it's really pretty neat.
That's very important. We remember when we were 20, we thought 40 was
Exactly.
old. So it's all about perspective.
Yep.
I was also reading, and since 2015, the GSA has released 2 of the CARER, and this is KAER toolkits, along with an update this year for intellectual and developmental disabilities. What does CARER stand for, and how does this frame your approach in these toolkits?
Great question. So I will say I spend most of my time on our CARE programs, and I love them. So the CARE acronym, KAER, stands for Kickstart, Assess, Evaluate, and Refer. And that started actually in the brain health arena, so to speak. Back in 2013, CMS approached GSA and said, people really aren't taking advantage of the annual wellness visit. And a key part of that annual wellness visit is screening cognition. And so GSA pulled together a work group. One of our work group members coined this phrase CARE. And so they put that out there as kickstart the brain health conversation, assess for cognitive impairment, evaluate for dementia if there seems to be cognitive impairment, and then refer for community resources. And if you think about this time when this was happening, this was 2015. So we weren't yet at disease modifying treatments, and the providers very often, and unfortunately continue to very often, kind of throw up their hands and say, well, why get an early diagnosis? What am I going to do anyway? And so the refer part of that CARE toolkit really stood to answer that, to say, if you can wrap that individual in appropriate supports and services and get education that they need and help their caregiver get the education and support they need, you can help that dyad, that caregiver and that individual, do the best they can as long as possible with function and quality of life where they want to be. So that was really what CARE answered. Then in 2017, GSA launched the first CARE toolkit for brain health. It was a giant toolkit that had all that was made to be a binder. All the pages were there of all the different assessments. That was redone in 2020 with a full literature search and all of that, and then redone to be more of an online format. It really still looks like a PDF, but it is online. And although it was redone in its entirety in 2022, we do update it on an ongoing basis with new tools and resources. Then in 2022, when you think about the similarities with obesity and brain health issues with cognitive impairment, nobody wants to talk about them. There's kind of that throwing your hands up. What am I going to do anyway? The lack of the providers really feeling like they can control the situation, the lack of the patients feeling comfortable with bringing that forward. And so CARE for obesity and overweight was born. And I joined GSA just as that was getting ready to go to design. And then we launched that in August of 2022. And that's gotten a tremendous amount of interest, again, because it's something that's such an unmet need. And then you mentioned that we did launch earlier this year a companion toolkit or companion guide to go with the CARE toolkit to meet the unique needs of individuals with intellectual and developmental disabilities, really understanding that the assessments and approaches and things that we use for the mainstream population aren't going to work for that population. And believe it or not, the interest that we have gotten for that toolkit is incredible. Just yesterday, I was providing a webinar on that. I get contacts about that at least weekly since we've launched it. It's really exciting to see what an unmet need that is. And one of the real exciting things that's happening is we are working on a new format for the CARE for Brain Health Toolkit. It should be launched around July. It won't look like a publication anymore. It will be a micro website and it will be out there. And the best thing about all of these is they're free. All we want to do is get folks to use them. We want to get them in the hands of primary care teams and others who can really help to drive practice change and begin to ask that question, are you having any changes with how you're thinking or your memory? Or begin to ask them, there's options available that we can help you treat that, your disease of obesity. Do you want to talk about what options are there for you? So it's all about kickstarting those conversations.
That's so important. You'd think that brain health and early detection for cognitive impairment would be fundamental in a primary care visit. And when I turned 65 last year and I had my first Medicare visit, I will admit that I only got 2 out of the 3 words correct on my mini cog, but I did get my clock drawing right. So that was nice to know that it is being done. I know when we talk about terminology and reframing our discussions, we're trying to get away from the term dementia to cognitive impairment. Do you think that that will soften and maybe ease the transition, jumpstart screening in a primary care setting?
So I think there's certainly the potential for that, but I would even go farther to say we need to talk about brain health. We need to talk about brain health before it becomes a problem. I always, when I talk about our care toolkit, I start with the audience and say, how many of you have had your provider listen to your lungs? You put a stethoscope on your chest, listen to your heart, check your blood pressure. And I say to them, have they checked your brain? And always the answer is no, they haven't. And I even think about as we counsel people who are in the primary care setting on diet or on smoking cessation, are we talking about exercise? Are we talking about why that stuff is also important for your brain as well? And so I think I use the example all the time. When did we get people to start sneezing in their elbows rather than in their hands? When we taught kindergartners how to do it. Right? So if we talked about brain health a little earlier or a lot earlier, could we maybe normalize the conversation so people are comfortable with talking about it with their doctor? And it should just be routine care. It delights me that you, who looks healthy and vibrant and walks in your office, the office and you're 65, they say, oh, we've got to do this, Sandy, because it's what the requirements are. It's what the best practice is. So there's really that opportunity, I think, to reframe it all around brain health and really looking at there's things, even when somebody has that early cognitive impairment or is diagnosed with dementia, there's action steps they can take to make their brain health better. And so we want to promote those things for people across the lifespan and not just wait till we're talking about it at a welcome to Medicare visit or an annual wellness visit.
So, and as a liaison and a subject matter expert for Medicare, are there potential reimbursement CPT codes for this detection, evaluation, diagnosis, and care planning around brain health?
There are. I want to put the caveat that the work that I do with CMS is all around resident assessment. So not, and then payment perhaps in nursing homes, but I do want to at least share some resources for primary care, and there are some great ones out there. First, CMS does have a cognitive assessment and care planning services webpage that's intended for healthcare providers that really helps them understand who can offer a cognitive assessment, where it can be performed, what's included in it, how it can be billed for, and all of that. So that information is pretty new to the CMS website it's definitely updated as of January of this year. There's also a resource that I want to mention that we link to in the care plan. The Us Against Alzheimer's group put out primary prevention recommendations to reduce the risk of cognitive decline. With each of those recommendations, and for the most part, those recommendations address people 45 and older. Certainly some of them could be applied to younger populations as well, as far as promoting brain health. But they do in that provide some different potential codes for non-Medicare and for Medicare wellness visits and things along with those primary risk reduction strategies. So that's a really great resource that we link right to in the care toolkit. I also want to mention our dear friends, Carolyn Clevenger up there at Emory, one of our superstar GAPNA members, and her colleague Laura Metters a year and a half or so ago recorded a podcast for GSA about using reimbursement really as a pathway to quality care. And although some of that information has changed, there's still some really great information in that podcast. And I think one of the most important messages in there is that the reimbursement does exist for comprehensive care, but it is that whole package of quality care, quality documentation, and leading to quality reimbursement. So I think that message from Laura and Carolyn was really important. I also know that they are one of the comprehensive dementia care models that's been kind of an exemplar in the guide model. And so I think we're going to learn a lot about how that new Guiding Improved Dementia Experience or guide model from the Centers for Medicare and Medicaid Innovation, how that really has the potential to transform care for people living with dementia, but also really focus in on the caregivers and really look at enabling the people to remain in the home and community longer because they are supporting that kind of pair, that dyad. And so I think we'll learn a lot about whether a payment model like that is feasible in the coming years, and certainly whether it does drive better, outcomes for the Medicare beneficiaries and their families, and just better services all around. So I think that's really exciting model.
And that really highlights the interprofessional approach that we take to geriatric care. So let's pivot and talk about your second care toolkit that tackles the management of obesity in older adults. And you stated in an interview, and I'm going to use your direct quote. So this is what you said, quote, "Aging and obesity have much in common in that nobody wants to discuss it. It's not sexy to age in our country. And I often say that ageism and sizeism are the last two acceptable isms," end quote. Now, although the AMA designated obesity as a disease in 2013, do you feel that the medical community still sees obesity as a lack of discipline?
There's certainly a lot of stigma and bias around obesity and people who live with obesity. And when I think of an older adult who's lived with obesity, perhaps for years, if not decades, the older adult has probably been told to eat less and exercise more 1,000,000 times. And they've probably been told it's just an issue of willpower. And if you just could do this or just could do that, you could achieve the best body, the right body size for you. And so I think that idea that obesity is a chronic disease and obesity is inextricably linked to so many other chronic diseases that as a provider, the provider is often chasing that other chronic disease. Here's your blood pressure medicine. Here's your medicine for your type 2 diabetes. Here's your medication for whatever else you have. And they're not treating that obesity in a comprehensive way. So when we think about a comprehensive treatment for obesity, there are lifestyle changes, there are diet and exercise, but we can't just tell an older adult, go out and eat less and move more. Older adults, as they need really special nutritional guidance, they need to get that protein. They need 30 grams on average 3 times a day. That's a good amount of protein. And as they're losing that weight, then they're not losing their muscle. We don't want folks who experience sarcopenia because someone just says the advice, just stop eating, eat a little less, and they're eating, lettuce and celery or whatever and no protein. We want them also to have not just count steps. We want them to have weight-bearing exercise. We want them to focus on balance. We want to focus on making sure that individual has the right sleep. We want to make sure they're getting the psychosocial support if they need it. When you think about relationships with food, there's family traditions, there's relationships with food about it being, this is a love here, I love you, I made you a treat. There's cultural issues around body size, a larger body size might mean someone is healthier or wealthier. And so the providers need to understand that and need to understand that obesity is a chronic disease that requires interprofessional, interdisciplinary care across the lifespan. It's not It's not a one and done. Here's your medication, or here's the diet you should follow. We'll see you in 6 months. This is working with a provider. And I think it's important to mention that the providers who will take the time and give appropriate care for people who live with obesity are out there. If the provider that a particular older adult is seeing, or anyone is seeing, about their body size isn't the provider who's willing to have those conversations, find someone who is. There's lots of providers out there who specialize in obesity medicine, who specialize in dietetics around helping people productively lose weight. And so we need to find those people.
And changing our, and I mean our as a provider team, is we change our perception. How can we integrate respectful and appropriate language when we talk to the older adults that may have body size challenges? And can you share some examples?
I think it's really important that we use person first language, and that we recognize obesity as a disease, and it's not what defines the individual. So it would be an older adult who lives with obesity, or an older adult who has obesity, not an obese older adult, and not an older adult who is obese. We don't want their conditions to define who they are. As a nursing instructor in my past, I would have a student say to me, it's the diabetics. Well, we would never say it's our canceretics, right? Or it's our heart attack etics. So why was it okay to say diabetics? And why is it okay to say things like morbid obesity? Just to think about, they are morbidly obese. What a horrible label for our patient who may live with obesity. So I think we can define, we can use more appropriate medical terms, and we also need to understand that the individual deserves a respectful dialogue around their body condition, and to understand that the person, their ideal BMI, and we could talk a whole day about why BMI isn't what we should be looking at, but according to their BMI, they should lose 100 pounds. Well, to just say to someone, you need to lose 100 pounds, instead of, let's make a small goal. Let's start with this goal. And if we can just lose 5 or 10% of your body weight, you might see a change in your blood pressure. Your knees might hurt a little bit less. What are your goals of care that you really want to accomplish? And then help tie those overall goals of care to then how can we address body size in a respectful way. And I would even argue that the journey into the doctor's office, as you begin, you walk in the doctor's office or the provider's office, and there's no chair that accommodates your body size. You walk through the hall, and there's the scale, in the middle of the hall, jump on the scale where everybody else is around, then go into the room and get up on the table, and here's your gown that it doesn't quite fit. And now, oops, I've got to go get the big cuff for the blood pressure cuff, rather than having that and making that assessment ahead of time that you need some different equipment. All of those say to these patients, you don't belong here in this space with us. And so I think to really just take that step back and look at the environment and look how the whole team really addresses body size. Is it respectful, and is it welcoming? Does everybody of every body size feel welcome in that office or in that arena? I think is really important.
That is such an important message for all of us, things that I haven't even thought of. So thank you. Thank you so much for sharing. I can't wait to get my hands on the obesity management of obesity in the older adult toolkit. Do you have any closing thoughts for us, Jen?
I just want to applaud all of my GAPNA colleagues. The nurse practitioners are out there providing holistic, person-centered care. The GAPNA conference will be coming up here not too long. This fall, I guess, right? But we'll come together and really celebrate all the innovative work. And it's always a pleasure for me to collaborate with my GAPNA colleagues and my nurse colleagues. So thanks for having me, Sandy. It was great.
Yes, I would really look forward to a live, not a Zoom meeting in San Antonio, so on the Riverwalk. And thank you, Jen, for being with us. And this is our inaugural GAPNA Chat for our 5th season. So for all of you, until next time, as you take care of others, make sure that you take care of yourself.
GAPNA Chat is owned and produced by the Gerontological Advanced Practice Nurses Association. All rights reserved. No portion of this podcast may be used without written permission. If you are an advanced practice nurse caring for older adults and want to further your career, GAPNA encourages you to sit for the Gerontological Specialist Certified exam and earn your GSC credential. This expert certification distinguishes APRNs with the knowledge and experience to manage the complex health needs of older adults. Visit gerocert.org to learn more. Jennifer Pettis is the Director of Strategic Alliances at the Gerontological Society of America. Dr. Cassandra Von S. is the Nurses Improving Care for Healthsystem Elders Niche Coordinator, Geriatric Oncology at the Moffitt Cancer Center in Tampa, Florida. She is a member of the Gerontological Advanced Practice Nurses Association communication team and is a host of the GAPNA Chat podcast series. For archived episodes of GAPNA Chat and to learn more about the Gerontological Advanced Practice Nurses Association, visit gapna.org. You can also subscribe to GAPNA Chat everywhere podcasts are found.